Social skills training has been around, of course, for many years. The first systematic applications of skills training to people with schizophrenia and other severe mental illnesses were in the late 1960s and early 1970s. And later in the 70s and the 80s, really the first rigorous trials of social skills training emerged. And fairly recently, Matthew Kurtz and myself did a meta-analysis of the research on social skills training. And what we did was we focused on research on people with schizophrenia in studies that were randomized controlled trials. We identified 23 randomized controlled trials with over 1,500 clients. And what we did was we organized the domains or the outcomes of the social skills training based on our theory about how the impact would be in terms of the proximity or the closeness of the outcome to the skills training intervention itself. In other words, the way that social skills training is hypothesized to work is that by practicing and teaching skills within a particular session, first of all, people master the content, the focus of the skills training itself. In other words, they're familiar with the steps of expressing a negative feeling or starting a conversation. In addition, that the teaching is expected to improve people's level of social competence, meaning their ability to use interpersonal skills in appropriate situations. I mean, the competence is a little bit further down the stream than the actual mastery of the content or the knowledge of the content. And so that's why we call it mediational. The idea being that as you become competent at a skill, you're able to use that skill in different situations. And then the ability to use the skill in different situations has an effect on your functioning, your social functioning, your self-care, your independent living. So then that's the intermediate level. In other words, that's a little bit further than social skills training, but still a goal of it's the primary goal of social skills training is to improve functioning. And then you have also intermediate negative symptoms. Now, negative symptoms, as they're defined, overlap with some functional measures. You have things such as apathy, difficulty establishing and following through on particular plans, or asociality, lack of pleasure and lack of engagement in interpersonal relationships. Those two are defined in ways that they pretty clearly overlap with psychosocial functioning. Then there are other aspects of negative symptoms that don't overlap so much in their definition, at least like inattention. So we expected that skills training would have an effect on negative symptoms, but not as strong an effect as on psychosocial functioning. And then last is symptoms and relapses. And you might say, well, why would you even expect it to have an effect on symptoms and relapses? But if you go to the stress vulnerability model of psychiatric disorders, schizophrenia in particular, this is a model that hypothesizes that the symptoms and the course of severe mental illnesses are determined partly by the degree of biological vulnerability a person has. It's determined by biological genetic type factors and other either biological or early environmental factors, and that this biological vulnerability interacts with stress, and that the stress that a person experiences also interacts with social support and coping skills. So a person who has really good coping skills, they may be exposed to stress, but they're able to manage that stress more effectively so the stress doesn't precipitate relapses. And social skills is conceptualized in the stress vulnerability model as a kind of a coping skill. Because if you have good social skills, you can get support for dealing with problems, you can get ideas in terms of managing stress, you have more reasons to live, and so on and so forth. So we expected that there would be a small effect on symptoms and relapses as people became more socially skilled and more able to manage stress. And interestingly, I think the effect sizes have changed slightly in the version that I gave you. I gave you the pre-publication version. But interestingly, the effect sizes. An effect size is just a measure of the magnitude of a treatment effect. And it's kind of the reason people use it a lot is it's a common metric you can use for any different treatment study, so you can compare different studies. And what you're doing in a meta-analysis is you're essentially pooling the effects across multiple different studies into effect sizes, and you're testing the magnitude. And in the language of effect sizes around 1 are considered large, around 0.5 or so are considered moderate. And so you can see, sure enough, that mastery of social skills training curriculum, the effect size was 1.2. That's a big effect size, no question about it. You can then see that the effect size for performance measures and also for psychosocial functioning were quite similar. I believe in the final analysis they're identical, actually, which is kind of interesting and raises other things that we could talk about at a later point. But in fact, there were significant findings on functioning and on performance tests along the lines of what were hypothesized. There was also a significant effect on negative symptoms. And that's interesting, we really don't have significant treatments for negative symptoms. I mean, the only treatments that are significant for negative symptoms tend to be psychosocial interventions, with skills training probably having the best track record and some evidence for cognitive remediation. And then there, in fact, was a small but still statistically significant effect on symptoms and relapses. So, in fact, the hypothesis about the effects of skills training kind of falling in this proximal to distal continuum was supported. So, I'm not going to go into different strategies for coping with many of the different problems. Many of them are described in our book and other books on social skills training, and you have the slides. What I want to do is kind of to zoom ahead just to the conclusions, because I'm kind of really up with my time. But one of the things I just want to point out is later in this presentation, there's a brief description, and there's more in the book about how we applied social skills training in a board and care residence, serving people with severe mental illness who were former long-stay state hospital employees. And a few of the things we did were somewhat different than the way traditional skills training has been applied, but I know more modern approaches, including some approaches that I think that Tom will be talking about, involve providing skills training at the actual residences where people live, and that becomes a very attractive alternative way of doing it. What we did in the board and care residences is that we both provided skills training programs within the residences, but also provided regular staff training meetings. And we developed a standardized structure for the staff training meetings. Provided a standard structure in which the goals of the social skills training group for a particular week were reviewed, in which we elicited feedback from staff members about particular social behaviors that were of concern. We were then often able to identify social skills or develop social skills for addressing the social behaviors of staff members. And then we were also able to help people develop homework assignments, staff members to help clients practice homework assignments that they could do in between sessions. So the staff training meetings served, in effect, to teach staff members about social skills training, to ensure the generalization of skills. In other words, people would be able to practice skills in their natural environment in the board and care home, and also in that way serve to create a kind of a social learning milieu within the residents that tended to promote the use of more effective social skills. Eventually, we started having different skills posted around in the board and care. Staff members were able to prompt people to use skills in appropriate situations when they came up. And we developed a variety of different social skills that we never had developed before. For example, what to do when you don't understand what the person is saying. When people were talking, very like in a word salad sort of way, or responding to false accusations. These things happen a lot when you have people with very severe psychotic symptoms living together. Or eating and drinking politely. You have people guzzling, piping hot, cups of coffee down, or locating your missed belongings. By the way, this is very useful for one's loved ones, including if you don't have people with severe mental illness. Where are my car keys? Those people tend to blame, So locating your missing belongings. We actually turn it into a social skill, steps of a social skill. It has two advantages. One is it helps people develop a skill for this. But the other is it helps staff members develop a standard way of responding to that kind of a situation. So I'm not going to go on any longer because I want to have time for Eric and Tom. But just to kind of wrap it up, social skills training is an evidence-based practice. I'm saying for schizophrenia, but also for severe mental illness. There's a lot of evidence indicating that it works for people who have social and functional impairments. Skills training is effective at improving the quality of relationships and also independent living, and it's been applied to a wide range of different areas of functioning and outcomes, in addition to relationships and independent living, but including other areas such as substance abuse, leisure and recreational activities, healthcare skills, and so on.